Okay. Good evening, everyone. I think we're going to go ahead and get started as it is 7:05 now. My name's Mihaela. I'm the Public Programs Coordinator at Historic Saranac Lake. So welcome to tonight's talk, Exploring Vaccine Resistance Past and Present with Deborah Brown. Thank you for joining us either here in person at the Founders Library at Trudeau Institute or through the live stream at home. Deb Brown holds a Ph.D. in microbiology and immunology. Over the course of her career, she has investigated the immune response to influenza infection and studied ways to enhance current influenza vaccines. She is currently the manager of educational programs here at Trudeau Institute, where she teaches an immunology course and supervises a hands-on research semester for Clarkson students, as well as directs the summer undergraduate research program open to undergraduates throughout the country. Before I hand things over to Deb, I want to thank North Country Community College and the Trudeau Institute for co-hosting this program with Historic Saranac Lake, and also thank the Trudeau Institute for sharing the Founders Library with us. This talk is one in a series of programs that Historic Saranac Lake is hosting throughout 2022, supported by Humanities New York. All of our past programs are available to watch on our YouTube channel, and a recording of this program, which is being live streamed tonight, will also be available on YouTube for later viewing. And with that, I will hand things over to Deb.
Okay, thank you, Mihaela, for that great introduction. And thank Historic Saranac Lake for asking me to give this talk today. I'm really passionate about the history of vaccines and how the past and the present with pandemics have come together to kind of put together this vaccine resistance that we see in modern times. So as Mihaela mentioned, I am first a scientist. I have a research lab here at Trudeau Institute. I'm also an educator, so I work on trying to get my teach immunology and the research enterprise to undergraduates. I'm also a little bit of an amateur historian. I really enjoy, like I said, the history of the discovery of vaccines, the history of science, and the history of our own town here, Saranac Lake, and the TB cure. What I'm working on currently is to become a better science communicator, and I'm hoping this talk today will allow me to do that. So there's going to be three themes through our talk today. First, we're going to be looking at infectious disease epidemics and pandemics throughout history. We're going to also be exploring the public health measures that led to prevention of these infectious diseases. And then along with that, we're going to explore some of the resistance against not only vaccines, but also public health measures in times when vaccines weren't available for certain diseases. So this is a little bit of a busy slide, but here's what I'm going to talk about today. So first, the top of this timeline here shows all the different infectious disease epidemics and pandemics I'll be talking about. I did throw in a little bit about tuberculosis here because this is Historic Saranac Lake, but I won't be able to talk too much about that, and I'll answer any questions anybody might have later. Down below is the timeline of when vaccines were discovered for each of these other diseases, these infectious diseases. And then what I'll spend most of the end time talking about a new type of pandemic called a pandemic of misinformation, and our current pandemic and the development of vaccines during this time and the concurrent vaccine resistance or hesitancy that we see now. So I want to just get everybody on the same page. There's 4 things to remember for my talk. First, viruses are bad, right? Influenza, SARS, polio, measles, they all work by attaching to our host cells, gaining entry, and replicating within the cell. And this is what causes disease. It tends to have killing effects on the cells, and the replication leads to disease. These viruses can also mutate and evolve, so it makes it very difficult to develop vaccines for certain diseases. The second thing to remember is that the main goal of vaccination is to prevent infection. And this shows a little infographic about how, especially in modern times, we're given a small amount of a harmless piece of the pathogen, like a protein or the mRNA that encodes the proteins. Our immune response acts to make antibodies to then go on and bind to this virus if we're infected with it at a later date. And so this is shown here with the same graphic. If influenza virus is trying to gain access to the cell, our vaccines have induced these antibodies, here in purple for flu and in blue for CoV-2. The vaccines induce these specific antibodies that bind to the virus to prevent infection. Now, vaccines can also prevent severe disease, and we'll talk about that later on as well. The third thing to remember is that the science is not perfect, right? Especially vaccine science that started in 1796 has come a long way since then. This early work was based on observation and anecdotal evidence, but the scientific method really allows for rejection of certain hypotheses and refinement of others, right? So in order to form proper conclusions about our work, our methodology needs to be looked at critically as well. And I'll show you an example of an instance where the study was flawed and led to a lot of erroneous conclusions, right? Fourth, the vaccine hesitancy or resistance has been around for a long time. Sometimes these two terms are lumped together, but I'm going to define them later on and how they can put into different buckets, right, of why people may be vaccine hesitant versus resistant. In 2019, the WHO had deemed vaccine hesitancy as a public health threat. And so the last part of my talk, I'll be discussing ways and how we can get better at communicating our science in order to answer these questions about vaccines and hopefully get a higher vaccine coverage in the population. Okay, so I'm going to start our walk through time here with smallpox, which was at that point the dreadful scourge of the human species. So smallpox has been basically talked about since the beginning of recorded history, right? The Egyptians talked about smallpox scars in that early time. I'm going to then talk about some ways in which smallpox was prevented by different vaccine mediators, and then I'll talk about in 1796 the father of vaccinology, Edward Jenner's work to really develop a vaccine that eventually eradicated this virus from the globe. And this is the only infectious disease that has been eradicated worldwide. And then again, these vaccine hesitancy and resistance follows along here. And even as early as the 1800s, there was a lot of resistance against these new vaccines. I should point out that this smallpox is also known as variola, and the early prevention was termed variolation, but cowpox virus is what's similar, and that's what was used as the vaccine strain over time. So here's some early attempts at vaccination. Again, I mentioned variolation was essentially crushing dried smallpox scabs and either inhaling the bits or scraping the skin to get them in. And once you made a response to that actual virus that caused disease, then you were immune to that disease and didn't catch smallpox later on. In 1774, Benjamin Jesty was a farmer and the first person to actually use cowpox virus to prevent this disease. He reasoned that since he had developed cowpox over time, he was a farmer, he inoculated his family in 1774 with the cowpox virus, and this protected the family from a later epidemic of smallpox that went through England. In 1777, in our new country here, George Washington actually had a mandatory inoculation for the Continental Army using this early variolation. And he basically, the troops had half of the troops the year before came down with smallpox. At the same time, the British troops were already vaccinated against this virus. So he made, he's probably the first to make mandatory infections for the military, mandatory vaccinations for the military. But really, Edward Jenner is known as the father of vaccinology, and in 1796, he conducted his experiment, essentially. He believed that milkmaids, again, this is the common knowledge in the farmlands of England at the time, that the milkmaids who milked all the cows were immune to smallpox because they had mild infections with this cowpox virus. So he went ahead and tested his hypothesis by inoculating this boy, James Phipps, with actually the cowpox scab from the milkmaid at the time. He went on to challenge James with smallpox and showed that he was protected. And so he wrote this, basically this first paper on vaccination against smallpox in 1800. But this basically then went on to have these mass vaccination sites that you can see in this picture, where they actually had to either scrape the cowpox vaccine strain from a milkmaid or from the cow itself, and people were being inoculated in these mass campaigns. As you can imagine, this was not without risk. And many anti-vaccinators at the time believed that this was witchcraft and it did more harm than good in people. And this is because the science at the time that many of these early vaccines were either a live vaccine, like the variolation, an attenuated form of the disease, like rabies or cholera, and that basically means the live virus that infects us has become weakened in another species, but it can still replicate. And then the other way of vaccinating at the time were live forms of an animal disease, such as cowpox for smallpox and Mycobacterium bovis for MTB. So you can imagine these side effects were plentiful. The other problem at the time was that, and I mentioned this, you can see it in the photos, you could only propagate the cowpox vaccine strain in people. At the time, the science did not know how vaccines replicated. They didn't know how to grow the vaccines, in culture or in other animals. So the transfer of other infections from people to people was clearly a risk. But overall, this vaccine resistance movement and the scourge of smallpox at the time really forced governments to analyze whether the rights of individual people were more important than the rights of the community, especially with smallpox that has a 30% death rate, right? And so most governments said no, the rights of the community at whole, were greater than the individual rights, so mandatory vaccinations in the UK started around 1850. But the vaccination, the resistance movement didn't really stop there, and so a famous person in this country around 1900 was Laura Little, and she blamed her son's death on the smallpox vaccine. But the idea of the timing of the vaccine and when the son actually died, as well as the son actually having diphtheria at the time, really indicated it wasn't due to the vaccine. But she went ahead and founded this magazine called The Liberator. And this condemned ideas of modern medicine and vaccination and believed that healthy living could cure people of all maladies, including infectious diseases and cancer. She was eventually arrested in North Dakota in 1916 under the Espionage Act because part of her vaccine resistance movement was to tell the military not to get vaccinated. And so this was not well held by the government. But this person, Laura Little, was the first to show that the anti-vaccine movement could really take hold, and that a mother's grief and suffering could really say to the public, like, hey, something's going on and we should resist this because, our children could be in peril. So then in 1901, we really had some good evidence that vaccines work. And this photograph was taken by a doctor in England in 1901. And you see this boy on the right had been vaccinated. The boy on the left was not vaccinated. And they were both exposed to a classmate with smallpox at the time, right? And so this showed that the vaccine really did help prevent people from getting smallpox at all. And so despite some of this resistance, again, the smallpox vaccine was the first and only vaccine to eradicate an infectious disease from the globe. And the UK eliminated smallpox in 1934, and then the WHO certified the global eradication of this disease in 1990. Okay, so the next back in time I'm going to talk about is the 1918 influenza virus pandemic. And it's important to point out that in 1918, scientists did not know what really the cause of influenza was. It wasn't until 1934 that it was shown that a virus actually caused this disease. In addition, a vaccine against influenza wasn't developed until the 1940s. And we know now that yearly vaccines are needed because this type of virus, influenza, continues to mutate. And this is shown here with the different colors on these different influenza pandemics across time. So the virus can swap these outer coat proteins. 1918, it's a blue one. 1957, it's a green one, et cetera, all the way up to our recent pandemic in 2009. What I do want to point out about going back in time in this example is that this is a great example of public health prevention campaigns and trying to flatten the death curve from this virus. It also illustrates the rise of really coordinated anti-public health measures campaigns against masking and other social distancing campaigns. So in 1918, there were public service announcements to help stop the spread of flu. And this shows a Red Cross nurse. The Red Cross was instrumental in making and delivering masks to people all over the country. And so to prevent influenza, do not take any person's breath. I thought that was a good thing to go by. But then the rest of these are really things that we've done with the COVID-2 pandemic, right? Where stay at home, wear masks, avoid people who are sick, right? Don't visit poorly ventilated places. So there was a big mask mandate across many cities in the U.S. at this time, and one of the mottos here was obey the laws and wear the gauze. Protect your jaws from septic paws. So again, I like these catchy mottos. And so many places had mask mandates that if you did not wear your mask, you were sent to jail or fined. And a $10 fine at that time was pretty hefty for 1918. Things got a little bit out of hand. A public health official shot 3 people over a mask debate. These were mask mandates that the police were expected to uphold. And so there were 3 waves of death during this 1919 pandemic, and I hope you agree that it looks very similar to what we've seen recently. And so in the US alone, 675,000 people died in the US and around 50 million people worldwide. I'm going to, in the next slide, show you some pictures about this War Bonds parade in Philadelphia and what happened after that parade. So this was a tale of two cities, and there was a war bonds parade in Philadelphia on September 28th in 1918. And you can see here they say about 200,000 people participated. There were no masks. People were shoulder to shoulder. About a week after that, that parade, 2,600 people died within that first week, and 4,500 died the following week. So we can see here, here's the 28th, and here's a real uptick in deaths from influenza in Philadelphia. And so what happened in Philadelphia, there was one of the first people that was infected with influenza was recorded on the 21st of September. The city did not put any mask mandates or social distancing ordinances or any of that until 2 weeks later on October 5th. And obviously the damage was done with this huge parade. In contrast, St. Louis had their first reported influenza infection on the 3rd of October and immediately put in mask mandates and social distancing interventions, and the death rate in St. Louis was much lower, and that did not spike. So these public health mandates did flatten the curve for this particular disease. And again, in other cities, this is showing San Francisco dropping of the mask mandates. There was that on 12 noon, everyone, we're all going to get rid of our masks. And here's the front page of the San Francisco Chronicle. And here's November 21st. And a few weeks later, there's again an increase in deaths. So with all these mask mandates and other social distancing mandates, you can imagine that resistance to these public health measures also ensued. So anti-mask leagues in California developed. There were posts in the newspapers to come to the anti-mask meetings, right? People believed that the masks were unsanitary and useless. And this is one of the first examples of a coordinated protest. There was about 2,000 people at this first meeting. They rapidly mobilized and they took donations to help fight these mask mandates from the Board of Health, right? So this is resistance to public health measures that people really could get behind. And again, with our current pandemic, we saw this same thing. Again, here's Sacramento in a protest against Gavin Newsom's mask mandates and social distancing mandates. And I just want to point out that the reasons for this in 1918, many people thought the masks really didn't work. They were unsanitary. They were gauze, right? But I'm not sure in this day and age, some people do believe the masks don't work. There was a lot of uncertainty around the messaging from public health and the government. But there's also people who just do not want mandates, right? And so we have to kind of unpack those and talk about resistance to mandates or resistance to the actual public health measures or vaccines. And we'll talk a little bit more about that in a bit. Okay, so the next virus I want to point out is poliovirus. And poliovirus was an epidemic in this country for quite a number of years. The epidemic peaked in 1952 with about 58,000 infections and 3,000 deaths. And this was really a scary thing, especially for parents. This virus attacked kids. There was non-paralytic forms that were a little bit more mild, but there were paralytic forms that really put kids in iron lungs or in braces. And again, this is similar to COVID-2. There was a post-polio syndrome that attack kids about 7 years after the initial infection that really was damaging. And I want to use poliovirus for two reasons here. First, it's a great example of, again, the stay-at-home orders and the closings of schools and things that people did on a public health scale to try to limit the disease. Second, it was one of the most successful vaccination campaigns in the country. And again, it was when science was really, virology was a burgeoning science, and people learned how to culture these viruses in cells and could really figure out what was happening with infection. However, I'll tell you in a minute, this was not without issues, and again, adds to a sense of potential vaccine hesitancy or resistance. So here's again a couple pictures from this historic time. In 1952, LA Hospital was full of patients in these iron lungs. They were paralyzed, and the iron lungs helped them breathe. I don't know if anybody watches Chicago Med, but last night there was a polio patient on there. So kind of looking at that. Also, this childhood disease was especially concerning for parents, again, because it attacked kids and it left kids disabled and really with paralysis. And so the rise of the vaccine development in this country kind of mirrored the poliovirus epidemic. And so people like Jonas Salk here began early polio vaccine tests in 1952. In 53, this scientist became a public figure. And this is one instance, again, where people seem to trust in the scientists and this vaccine development that, you know, we're going to figure this out for poliovirus. There was a huge vaccine field trial with 1.8 million children, basically a big phase 3 study that took a whole year to complete, and they didn't have the data until 1955. So they went ahead and manufactured inactivated poliovirus around the country. And so this was basically the poliovirus that was rendered inactivated so it couldn't replicate in cells by something called formaldehyde. So of course, there were some problems here. The Cutter incident is one of the important historical things that happened here that kind of lends to the anti-vaccine movement, because this lab in Berkeley, California, did not follow the correct protocol to inactivate that virus. So what happened was poorly inactivated virus got out to doctors' offices and vaccine sites, and so kids were actually infected with this. However, there's a good part to this. The silver lining of this was that the government mobilized immediately. It stopped all production of the vaccines, and this was not unlike what happened to the Johnson & Johnson vaccine, where it was stopped to really study these adverse events. So they stopped production. They went through and did better inactivation protocols and made sure that all these labs were on board before putting this vaccine back out to the people. At the same time, a little while later here, Albert Sabin was also developing an oral poliovirus vaccine, which was an attenuated vaccine, again, weakened, and that was taken orally on a sugar cube to also prevent polio. So the good out of this, or what we can look to in the future, was this idea of these mass vaccination campaigns and how people like celebrities and the March of Dimes really came together to promote the safety of these vaccines and to promote, basically everybody, all kids getting one and everybody getting the polio vaccine. And this in 1962 in San Antonio shows lines around the corner. Again, not unlike when the vaccine first rolled out for COVID-2. And I don't know about you, but I was up at Plattsburgh in at the airport hangar with a line of cars receiving a vaccine. And so, again, another thing I want to point out here, David Oshinsky, who's a Pulitzer Prize-winning historian, wrote a book called Polio, An American Story. And he believes it may have been the high point of respect for scientific discovery during this time. People got behind the scientists, got behind the vaccines, and so helped eradicate polio from the US. And again, this is another graph where you introduce a vaccine in 1955. This was the inactivated vaccine. In 1963, the oral poliovirus vaccine was invented. And then in 1979, the US was declared polio-free. But this virus is still endemic in other parts of the world, and this is a more recent photo in Sierra Leone, where many children contract polio even now and have this disease for life. Okay, the next one I'll talk about is measles, and then we'll get to our present day. So again, measles was an example of a really successful vaccine campaign, and this disease is really highly, highly contagious. So this little R0 number up here, which means the reproductive rate or how many people are infected by one person already infected with the virus. So this R0 number is between 12 and 18 for measles. So if one person has measles, they can infect up to 18 other people. In comparison, for COVID-2, the RO for the original strain was about 2.5. For Delta, it was higher, to 5 to 8. And we don't know really yet with Omicron what that number is. So a really highly contagious disease, again, a childhood disease, and it was in this country from 1912 to 1960. Vaccines were developed during the 60s. One, again, was an attenuated measles virus. The second one in 1968 was a better attenuated measles virus. And then by 1971, the MMR vaccine was introduced, which included measles, mumps, and rubella. And I'm going to spend a little bit of time talking about that because it really leads me to my 1998 story and the Andrew Wakefield studies. So I'll get to that in a minute. So measles, again, so highly contagious that you have up to 200 to 800,000 cases per year. And most symptoms weren't that bad, right? There was the rash that came with a cough, runny nose. The biggest issue were complications from this virus that led to pneumonia, encephalitis, death with 1 to 3 children in 1,000. And then again, if you got this virus during pregnancy, it really added to complications for your pregnancy. And kids that got a particularly severe form, it was, if kids got this subacute sclerosing encephalitis, it was fatal. There was no way to treat that disease. So the vaccine campaigns came out, right, with stop measles with just one shot, and we should all get our babies vaccinated. And so this MMR vaccine, again, the vaccine strain came out in 1960. Only 6 years later, after John Ender's lab actually isolated the measles virus. But they first found that this killed virus vaccine, so unlike polio, if you just killed or inactivated the virus, you couldn't get a good enough immune response to prevent the infection. So they went on to do, as I mentioned before, an attenuation, and that means weakening the live virus. And so that worked in 1963, and it was licensed. By 1968, a guy by the name of Maurice Hilleman, who was a really important vaccinologist, worked to attenuate this measles vaccine even further, and also worked to help develop the mumps vaccine and the rubella vaccine. And so by 1971, we had the MMR combination vaccine, and that's what's been used since then. So the measles vaccine could have eradicated this disease from the U.S., but unfortunately, down here you can't really see because the scale is so high. But in the last decade, even the last 10 to 20 years, I'll show this in a minute, we had an uptick of measles infections around the country. And this was due mostly because of a vaccine refusal for parents to get their kids vaccinated, right? And this was due to this one fraudulent paper that was published by The Lancet, pretty good journal, in 1998. And the problem with this paper, well, there were many problems. This is actually some case studies that I used for my undergraduates on scientific ethics, right? So there was a very low number of children in this study, first of all. It was a self-identification study by the parents. 8 out of 12 with the onset of symptoms was associated with the MMR vaccine. The primary author at the time was working on a lawsuit with the anti-vaccine companies. And then it was found later on that someone looking into this, some of the symptoms and the onset that was reported in this paper didn't actually match those original children in the study. So there were quite a few things wrong with this paper. And by 2010, it took 12 years to retract this paper. And it was retracted by The Lancet. So anytime you try to download it, there's this nice red retracted sign on here. But unfortunately, the damage was done, right? And this started the whole movement of vaccines cause autism and the anti-vaccine resistance because of this, right? So in 2007, Jenny McCarthy was really vocal to convince the public that vaccines were harmful and they caused autism, especially the MMR. It was later shown that in a couple, well, more than a couple, in a number of studies, it was shown that the MMR vaccine did not cause autism. But there was one early on in 2005. This was a really well-controlled study because Japan had discontinued the MMR vaccine for other reasons in 1992. So they had a cohort of children that never received the MMR vaccine, and they studied them for 7 years. And they had that other cohort that did receive the MMR vaccine. And so when they compared the incidence of autism between these two groups, it was no different, right? So even in an unvaccinated child, the incidence or risk of autism was similar to the vaccinated child, right? So scientists, especially Dr. Paul Offit, he writes a number of books about this topic. He's the director of the Vaccine Education Center, and he's a pediatrician in Philadelphia. And he does little recorded videos, basically, about vaccines and autism and how vaccines work. And so it's really great to check that out if you're interested in that. So, okay. So the resistance to this childhood vaccination really showed increases in measles incidence in the last decade. And again, 2014 was the big measles outbreak at Disneyland. And then again, in 2019, we had a huge number of measles cases in this country. And again, this is a vaccine-preventable disease that kids don't need to get. Okay, so that brings me to my latest, our latest pandemic. And I'm going to talk a little bit, I'm not going to actually talk too much about the science behind COVID-2 or the vaccine behind COVID-2. That would be a whole nother talk. I'm really going to talk about this rise of the pandemic and of misinformation, the different vaccine resistance groups that are out there, and how we can try to be better at communicating our work so that we can try to get better vaccine coverage around the world. Right, so we all know this virus has been around, swept the globe very quickly. There have been public health policies in place. I've touched on a little bit of those, right? The things that we saw throughout history, like masking, social distancing, closing of schools and other public places. But there have been a lot of critics of public health policy and vaccines, especially on social media. And so this has led to what some call a pandemic of misinformation in the time of social media, and it really brings into other, social science things like First Amendment rights versus putting out accurate information. And I want to point out, remember number 3, the science, right? The science changes, right? Science is not immutable, and I think a lot of the public thinks that, well, why is public policy changing all the time? Why don't we know whether to wear masks or not? Well, the more we learn about the virus and the more we learn about the vaccine, our conclusions change, and the way that public policy needs to be set out also changes, right? So way back, if we can call it way back in history now, 2020, but way back at the beginning of the COVID-2 pandemic, the director of the WHO, we are not only fighting this infectious disease, we're fighting an infodemic, and that fake news spreads faster and more easily than the virus itself, right? And I would say maybe more dangerous, right? And so the misinformation's traveling fast and gets shared more frequently among groups than the accurate revised information, because we as scientists, again, or people who write about science, have to make sure it's right? It takes longer to put out accurate information than inaccurate information. And this, again, is a quote by Winston Churchill: "A lie gets halfway around the world before the truth has a chance to put its pants on." So this rise of social media has contributed to these anti-science attitudes and the anti-vaccine movements. And so, again, she calls this echo chambers, right? Because the people who share this information are just bouncing off of other people who want to share or want to hear that information. And then on top of that, you have a financial model that if you get more likes or you get more tweets or whatever happens, then that rewards these posts that are widely shared. I also want to talk about a little bit confirmation bias, right? And it's mostly talked about with anti-vaccine supporters to really focus on the 1 in 200,000 people who have had an adverse event against a vaccine, rather than focusing on the 1 in 150 or 1 in 100 people who die from COVID, right? I do want to point out, though, that confirmation bias isn't just on the anti side, right? I think scientists do this too. We want to find evidence for our hypothesis, right? So we have to be careful as well with confirmation bias, and I think we're conscious of doing that, and we try not to do that. And even news media outlets now too, they give different data sets to support their reporting on a topic, and then they're often asking questions that we don't have the yes or no answer to. So all of this together has really led to a rise, I think, in vaccine resistance and anti-science attitudes. So to combat this, scientists have also taken to Twitter. They do podcasts now, they blog, and a couple I just want to point out, your local epidemiologist, get a chance to check out this blog. She's great. She gave a talk here a couple weeks ago via Zoom, and she's really good at breaking down the data and making it and giving it to the public in bite-sized bits, right? And she has about 309,000 followers. These other people, I'll talk about Rhea Boyd in a minute. Dr. Jenner's house, that's a cool place for vaccine history. Akiko Iwasaki, a Yale professor. And these podcasts about the immune system and virology. But the problem is, again, if you look at the followers for people like Joe Rogan, like Sean Hannity, so the messaging is being bounced around a little bit more frequently. That might be the misinformation than the people who are trying to give accurate information out, right? So this is something we have to think about when we're trying to do science communication to the public. So as I mentioned, the WHO lists the vaccine hesitancy as a top 10 global health threat in 2019. And it's really a delay in acceptance or refusal of vaccination. And I want to point out that this kind of bucket, this definition is very wide, and I'm going to break it down a little bit for you. So vaccine hesitancy really can be kind of, well, I'm going to wait and see. There's maybe some distrust about the vaccine. But then on the resistance and refusal side, there is a misconception that, people don't want to get a vaccine because they don't think they're going to get very sick. It's going to be like a cold. I'm going to be fine. And that the vaccine doesn't prevent people from dying, so it's not working, right? And then a big majority of the vaccine refusal groups believe that individual freedom is more important than public health and protecting our neighbors. So again, this is pulled directly from some pictures recently of the anti-vaccine movement. And again, you see these other buckets. I want my freedom, I'm going to be fine, and my body, my choice. Okay. So the unvaccinated group are 10 times more likely to die due to COVID, and that's been shown both for the Delta wave here, it was quite high, and again for the Omicron wave. And so why are these people not being vaccinated, right? And this brings me to Rhea Boyd. She's a medical doctor. She's a master's of public health, and she really is talking about the monolith, the unvaccinated should not be put into one big bucket, right? They're not a monolith of anti-vaxxers, and we need to find the reasons for not getting vaccinated, so then we can talk around that and listen and try to give some information to help, right? So some of these are people without access and kids under 5. That's why they're not vaccinated, right? Other that I would group into the vaccine hesitancy part are wait and see. I want to know about safety. I'm concerned about side effects. Maybe it was developed too fast. I don't really know. And those are all, again, what are termed vaccine hesitant. And then there is a group here that is vaccine resistant. They won't get the vaccine, right, at all. And so what Rhea says, that we actually have to put in work to help them understand these other wait and see questions, the develop too fast, concerned about side effects, right? And so we also, some of the unvaccinated are underrepresented people, and she has something called the conversation to reach out to these communities. Right, so there's this wide range of vaccine coverage around the world. Again, I want to point out this light colored here in Africa is really about access. So we're not going to talk about that too much. These other places, China and Canada, have really high vaccine coverage. But then we're not, we could be better. And so what are the reasons behind this, right? And so especially, here's our great state of New York. We have some real pockets of low vaccine coverage that are potentially in these rural areas. And so what I pulled here, just finishing up, is from this Kaiser Family Foundation study. This is a really great study because they started it in December of 2020, and they're still collecting survey data now. And so again, this is if you're interested in this, it's the COVID-19 vaccine monitor. And at the beginning, there was concern about side effects was the top reason why people were not getting vaccinated, right? And so again, well, what would motivate you? Well, I'm going to wait to see more data on that. Okay, that's all good. Also, rural residents from this survey, it was shown that the rural residents here, 40% were worried they or a family member would get sick. So there's a little bit of a difference here between the rural residents and urban and suburban in thinking that the virus is going to get them and they're going to get sick, right? They also think the seriousness of coronavirus has been a little bit overblown. We haven't seen it here too much, so it's really not that big of a deal, right? And again, they're less likely to wear, because of these views, less likely to wear masks going out. I should point out that this was about a year ago. So like I said, it started in December 2020, and they're collecting data all along. And so they think that vaccine uptake in rural areas may actually lag behind. Again, this is March 2021. And at first here, a higher percentage of the rural residents had gotten their vaccine by March 2021. But the concerning number here is that there is a higher population of the definitely not group at 21% that will not be vaccinated. So, right, why is that? Well, a lot of the unvaccinated people actually believe the vaccine doesn't work. And so if you look at this graphic here, 84% of unvaccinated people believe the vaccines are not working because there are breakthrough infections, right? And so, okay, well, I just told you that vaccines aim to prevent the infection, and now we're having breakthrough infections. And that is true in some cases, right? These vaccines, or these viruses, COVID-2, we've gone through about 3 different variants so far, 4, I think. And so the virus mutates, and sometimes the vaccine isn't quite the lock and key, right? But here, if you're vaccinated, you believe, where are we here? 77. You believe the vaccine is working because there's less hospitalizations and less death in the vaccine cohort, right? So it's really interesting, I think, to see the views of the unvaccinated and the vaccinated groups to try to get at these ways to explain, well, not all vaccines prevent infection. Actually, the tuberculosis vaccine, BCG, doesn't prevent infection. It just prevents severe disease. So I think that's something that we don't talk about as much. So the good news is, though, what we have is this wait and see group here in blue, starting in December 2020. That group has gotten much smaller over time, right? So now most of them don't need to wait and see anymore. They've gotten vaccinated, right? So again, what this surprisingly stable percentage is up here, is the definitely not group. And that seems to not be changing over time. So, how do we get that? Do we get that to change, and how do we, right? And so the KFF, if you go onto their website, they've got these nice little videos that break down this data for you, and you can look at that. And one of the things I showed was just previous to that. Okay, so how do we go forward now? So where do we go to either educate people more who really don't want to get a vaccine or don't believe it works? Can we change the mind? Can we build back trust? Well, I think we really first need to acknowledge what's happened before, right? The good and the bad. We've had some, as scientists, some not so good results in the vaccine sphere. And I think we need to claim that and acknowledge that. We've had a lot of good in the vaccine sphere, but there have been a couple mishaps, right? The 50s and the 60s may have been the heyday of the public's trust in scientific discovery, and how do we get back to that? Can we get back to that? And I really want to point out, we have there's a documentary on Maurice Hilleman that we show the students. He was at Merck for many years. He developed 5 of the 14 vaccines that are still given. And he was very concerned about the vaccines doing more harm, and would pull the plug on these projects if he thought that that there was animal byproducts, there was impurities, right? So today's vaccines don't contain any infectious material at all. It contains a blueprint really to make the proteins and a little bit of fat particle to get it in, right? So of all the vaccines we've had, today's vaccine against COVID-2 is probably the safest out there in terms of the composition, right? And so they're safer than they were in the 50s and 60s. So one of the things I think we need to do, and it needs to start, like this, right? Like us giving talks. So we need to be better in science communication. And I really don't mean like we're taught how to do science and then communicate it to people that we know, right? What we're not trained in is how to listen to the public, how to change the apples into the oranges, right? We need to understand where the public is coming from and then try to move the message there instead of all the time our message is apples and everybody they're not listening, right? So one of the things that we have to do, and I know many of my colleagues are trying to do this, and that's why I kind of jumped at the chance to give this talk. I want to get better at doing this. So in conclusion, I'll end here. Really, vaccines, the history of vaccines have been met with a history of resistance to those vaccines. Although with this resistance, we've seen that vaccines have dramatically decreased death and suffering on a global scale. There's a new infodemic, a new pandemic of misinformation that I think contributes to a greater rise in vaccine resistance. And a lot of social media is adding to this problem. And then finally, as scientists, I think we need to start these grassroots efforts. We need to network between our good science communicators so we can learn from our peers and learn from other people and how to share this information. And so I'd like to acknowledge, obviously, Historic Saranac Lake and their partners for inviting me to give this talk today. And if anyone is interested, I have a whole list of books on this topic. YLE has an archive of since March 2020. She's been writing about this pandemic. These sites, the home of vaccination and the history of vaccines, are awesome. And these books by Paul Offit are really easy to read. This is about Maurice Hilleman, and it is one of the best kind of books about science you can read. So with that, if there are any questions, I'll end up there, and thank you all for coming and listening. If there are any questions, I can take some. All right, well, if there are no questions, thank you again very much. My mask on.
Thank you, Deb. That was an absolutely fantastic talk and so informative. If questions come later, do feel free to email us at the museum, mail at Historic Saranac Lake. If you're maybe digesting information, we can pass those along to Deb and help spread more of this information and science. So thank you, Deb, for taking the time and all of your great work in putting this talk together. Thank you, Chris Friars, for running the live stream behind the scenes. And thank you all for joining us. Please do check out our website, historicsaranac.org, for future programs like this. And please feel free to reach out with any further questions.